Okay, I've got 8:01. Good morning. We're going to give it one more minute and then we'll get started. Thank you. Okay, good morning. I have 8:02. Welcome to the Maryland Prescription Drug Affordability Board. I call it a work session. My AG calls it a meeting. But nevertheless, we hope to get some good dialogue between the board and the staff together today. Thank you all for joining. Christina, do we have a quorum? Although we're not taking any votes other than the minutes.
Would you like me to call roll, Van?
Sure.
Roll call. Van Mitchell,
Here.
Gerard Anderson,
Here.
Stephen Rockhour,
Here.
Joseph Levy,
Here.
Barry Nukwuga.
Here.
Yes, we have quorum.
Great. Being all present, not pleasant, or both. Call the meeting to order and motion for approval of the minutes for January 27th, please.
So moved.
Jerry
Second.
motion, second by Stephen. Any additions or corrections? Hearing none. All those in favor as submitted, aye.
Aye. Aye. Sorry.
Opposed? Great. Thank you very much. Opportunity for public comment. I know there was 135 pages of written. Any public comment, Christina?
We did not receive any requests for oral public comment. And you were right, Van, there was 130 pages for the UPL regulations process. For this meeting, we did receive 2 additional written comments, which were shared with the board and also posted on our website.
Yep, got them. Okay, with that, we're going to start into the work session. And I'll turn it over to Andy and Christina and Michelle for guiding us through.
Great. Thank you, Chair Mitchell. Well, first, thanks everyone for joining in this early morning session. And the team also wanted to thank all of the commenters that provided such thoughtful comments on these important regulations. As the chair mentioned, and as Christina confirmed, we received about 135 pages of comments that were shared and reviewed by the board. Those are posted on our website in our regulations section under the proposed regulations. And given the extensive comments that we received, we scheduled this separate working session to go through each of the comments in detail. Because there are so many comments, we've broken the comments into 2 sections that we can go through, so we can go through each one in detail. Today, we're going to be going through the first group of comments, but if you don't see any comments, if you see a comment that isn't in this presentation, we'll likely try to include it in the second presentation. So there will be a second presentation. Go ahead.
Excuse me, Andy. I forgot to say, I just wanted everyone out there who maybe hasn't had the pleasure of reading through everything. I don't want you to think we had 70 some pages of individual companies or groups comments. We had 135 pages. Of that, 99 were 3 individual, 2 companies and 1 association. So, you know, the bulk, 99 of the 135 were in 3, what I call 3 groups. Thank you.
Yeah, thank you, Mr. Chair. But we did get a lot of really good and thoughtful comments. So we did want to set this presentation up just to go in detail. In previous regulations, a lot of them haven't been so kind of novel and new. So a lot of the times we've gone through at a 50,000-foot level, summarizing and discussing each of the comments. But based on the complexity of these regulations and the volumes of comments, we are going to use this working session for the board to discuss the comments at a more granular level. But again, this is part one of part two. Any issues that are left unresolved out of this meeting, we can address in the upcoming meeting. Next slide, Christina. So just as a reminder of what these regulations do is they create the policy review process. And at a very high level, the first step of that process is that the board will make a preliminary determination as part of their cost review study process. If the board decides that the drug does not cause an affordability challenge on their preliminary determination, there's no further action. We just complete the report. However, if the board does make a preliminary determination that the drugs cause an affordability challenge, this creates this new process where the board basically tries to answer the question of how do you address those affordability challenges. So the first step is to, once you've identified that there are challenges, you need to identify the drivers of those challenges and then the recommended policy solutions that address the drivers that you've identified. And we've also, in these regulations, have two sets of policy options. There's the upper payment limits, which is something that's specified in our statute and we address in these regulations. But then also the board indicated they want to be able to consider non-upper payment limit policy options. And each of those have kind of a different but parallel track. Again, partially just because we do have the authority to set upper payment limits. So it's just a different process for finalizing those recommendations. Next slide. So again, just as a reminder, we're establishing the policy review process that examines policy options, including both UPLs and non-UPL options. Please keep in mind that non-UPL policy options are made as generally recommendations, or they're made as recommendations. First, the board staff will gather and identify the drivers of the affordability challenges, and then information on the potential policy options, both UPL and non-UPL. Then board staff provides recommendations to the board regarding the policy options that address the drivers of the affordability challenges that we identify. And one of those policy options may include UPLs. It can also include non-UPLs, or it can be one or both. And then finally, the board makes non-UPL policy recommendations. Oh, excuse me. The board may provide feedback and board direction to the staff. And then the staff begins the process of actually calculating the UPL numbers for board discussion. And then finally, the board can also make non-UPL recommendations by resolution. So just flagging that the outcome of each of these two processes is slightly different. Again, non-UPL policy recommendations are going to be done by resolution, and the board establishes UPLs by adopting a regulation. So that's just a quick reminder and overview of the process that we're discussing today. Next slide. So folks will know that we proposed a set of regulations. The first set were definitions. We created new regulations for the hearing procedures and then created a new chapter of regulations concerning policy review, final action, and upper payment limits. The proposed regulations were in the January 10th register, and comments were due on February 10th, 2025. 13 organizations submitted comments, and these comments were shared with the board and posted on the website. Next slide. So again, there were 13 commenters, and the comments totaled approximately 135 pages. All commenters submitted new comments, approximately half of the comments that came in, or half the volume of comments that came in. And then 3 commenters resubmitted previous comments on things like the upper payment limit action plan and then draft versions of the regulations. So they kind of resubmitted those comments for the board's consideration. There were 4 letters representing the pharmaceutical industry and manufacturers, 7 letters representing patients and patient advocacy group, 1 letter representing payers, and 1 letter from pharmacies and wholesalers. The comments range from being fully supportive of the regulations and approach to comments that had concerns and feedback on specific issues with the procedures created by the regulations. Those are the comments that we're going to go through today. We tried to organize the comments by topic. Next slide, thank you. So you'll see that we break them up into separate topics. This first section is going to look at definitions, procedures, and interpretations of language. So if you go to the next slide. So one commenter stated that the Maryland APA requires the board to explain its reasoning for declining to make recommendations, and our staff recommendation is no action. We disagree with the commenter's statement or interpretation of the APA and rulemaking requirements. Next slide. And then, Mr. Chair, I'm going to just go through these one by one. I think board members should feel free to interject with questions or comments throughout the presentation, if that's okay. I don't.
Absolutely. I would prefer that everyone participate throughout the morning as opposed to waiting till the end.
Great, thank you. All right, so yeah, I'll open it up for questions or comments. Some of these board members don't feel like they need to react to every slide, but I will kind of open it up for comments and questions for each slide. So the next comment that we received was on the definition of an affordability challenge. The commenter urged the board to revise its proposed definition of an affordability challenge. The actual language that they're talking about is, for the purposes of this chapter, an affordability challenge refers to either a high out-of-pocket cost for the patient or an affordability challenge for the state healthcare system. And the staff recommends no action. This isn't necessarily a definition, but it's a shorthand reference referring to the two statutory assessments. And this shorthand basically avoids the repeated use of the full language. So if we did not have the shorthand, we'd basically be using that entire language of high out-of-pocket costs for patients or an affordability challenge for the state healthcare system. So this is just a shorthand that we have applied throughout the regulations. Any questions on that?
No.
Okay.
No, we're good.
All right. So this one is kind of technical. The commenters urged the board to clarify system net costs, alleging that the term relies on the definition of net costs. And the commenter also asked the board to provide additional transparency regarding on how it intends to calculate this metric. And we included the two definitions in here just for your reference. And the staff recommends no action, but I think it's primarily just a clarification of understanding for the commenters. So in part of this regulation, the system net cost is not meant to be a specific calculation. It basically provides the definition of what the UPL value represents. So one commenter recommended adding system net cost as part of specific calculations. So there's two methodologies that refer to net cost. That's our therapeutic and domestic reference pricing methodologies. And one commenter basically said that our use of net cost should be system net cost because we want to make sure that we include out-of-pocket costs as accounted for. Basically wanted us to include out-of-pocket costs when we're actually doing the UPL calculations. And we have a mechanism for capturing contextual information that includes out-of-pocket costs. So we actually think that out-of-pocket costs is accounted for in the contextual information, so there's no need to actually add this system net cost. Another commenter requested that the board provide the specific methodology for calculating the net cost. And basically, under the proposed regulation, the staff posts a description of the calculation and analyses for relevant underlying assumptions for public comment. Sorry, Christine. Yeah, this is definition of system net costs. Thanks. Underlying assumptions for public comment. So basically, the process is we will post what the description of the calculations and the analyses for calculating the UPL, and the public then gets to provide their own calculation and assumptions as part of this process. So the way that our process works is there's no methodology to post on the front end. However, we will post the methodology itself, the actual calculations themselves, and then the public gets to comment on those. So there's a process for the public to actually kind of weigh in on exactly the assumptions that the staff is making. So again, at a high level, it's kind of, again, a conceptual issue. It's, again, the definition describes the concept, but doesn't describe a specific calculation. So it's almost like the comment is like asking for something that doesn't exist. So I think that, so the staff recommends no changes, and I think hopefully this clarification explains it. I know it's probably a very technical response there, but did want to answer any questions or clarify things for the board if there's any questions.
So this makes complete sense to me. Each insurer might have a different way of doing these kinds of things. Each PMM might have a different way of doing things. So I don't think you have one system. So I think you have to give a little flexibility to doing it. But I think it's very important that you actually do put in the dollar amount of all these price concessions, discounts, and rebates, which you are already doing.
Great.
Yes, I agree.
We do appreciate the close read from the commenters, though. There was a lot of it clarified our thinking, just making sure that we were on the same page, and the regulations were saying what we intended for them to say. So we do appreciate those careful comments and review of the comments from the commenters.
No, I had a chance to read all of the comments, and I think that they are doing a great service to the PDAB to actually do such a close read to this material. So I really appreciate everybody's efforts in making this better.
Okay, with no comments, I'm going to go to the next slide. Comment on confidential, trade secret, proprietary information. So commenters allege that the board has not addressed how to implement statutory confidentiality protections and protect confidential, trade secret, and proprietary information against public disclosure. Staff recommends no action. When we adopted Regulation 04, the staff explained during the meeting that the board's internal procedures for managing the proprietary information are not subject to APA rulemaking. So not much to say on this, just that we do have an entire set of regulations specifically addressing this issue. Any comments or questions on this? All right. Next, the specific timelines for providing notice of board information and gathering hearings. So a commenter requests that the board specify in regulation the advance notice that will be provided of a board hearing, the informational hearings, technical hearings, and specify the time in which an agenda or materials related to those hearings will be provided. Staff recommends no action. And basically, the regulations include advance notice of information gatherings and hearings, but allows for flexibility in scheduling. Because can be different formats for each of these different hearings, and because some of these hearings may require scheduling with different stakeholder groups and things like that, we believe that it's important to allow flexibility in that scheduling. And we don't recommend having specified time periods in the regulations. Any comments or questions on that? All right, hearing none. Recording and posting board meetings. A commenter requests that regulations be adopted requiring that all board meetings, and this seems to include informational hearings and technical hearings, be recorded and made accessible on the board's website within 48 hours. Staff recommendation, we recommend no action. Presently, board meetings are recorded and posted as promptly as possible, just based on the technical capabilities and restrictions, and then posted as soon as possible. Proposed regulations for informational public hearings and technical meetings will provide for our current regulations do provide for recordings of those hearings. So we don't think there's any action that we need to take. I think this has already been addressed through our current work. Any comments or questions? I'm glad we have some slides that we can go through quickly. Next question, multiple commenters request that the board strike the provision giving the board chair or staff designee the power to limit repetitious testimony in a quasi-legislative hearing. Staff recommends no action. So you can see the language here in 14010106C2B provides the chair or staff designee shall give all persons who register the opportunity to speak, but may limit repetitious testimony. And this basically provides an appropriate time management tool rather than imposing any specified limit. So the regulation gives everyone the time to speak. This is just a time management tool, and depending on some of the kind of structure of some of these informational hearings, it may be a necessary tool to just protect the board and staff. So it's a common provision, and we recommend maintaining it. Any comments or questions on this? All right, seeing none. So this is another technical question. but pretty quick to go through it. So the commenter's interpretation of state healthcare system. One commenter interprets a state healthcare system to mean the specific state entities that could be subject to the UPL, i.e. state or county correctional facilities and their patients, state hospitals and their patients, health clinics at state institutions of higher education and their patients, health benefit plans, making payments on behalf of the state or local government, and enrollees thereof, and to the extent legally permissible, the Maryland State Medical Assistance Program and Medicaid enrollees. The commenter requests that affordability challenge include consideration of both the net price at which the state healthcare system entities currently access the drug and the level of purchase and utilization by those entities. And in short, the staff recommends no action here. We disagree with the commenter's interpretation. State healthcare system means the healthcare system of the state of Maryland, not only governmental health systems, where and there are some other technical definitions such as state health plan that have specific meanings as well. But we just disagree with the commenter's interpretation of this term. So any comments or questions here?
Yeah, Andy, I didn't quite follow that. I mean, aren't these the entities that we are in fact involved with sending UPLs on?
Yes, yes. I think the comment was getting at the fact that our cost review studies are for the state healthcare system, which we read as the entire state healthcare system. But the UPLs are applied to regulated entities, our governmental our governmental entities, which is the ones that are subject to the UPL. So I think they were commenting on the differentiation between the scope of our cost review studies and the application of upper payment limits. But the statute clearly states state healthcare system, and then creates a different list for UPL. So this is, does that make sense?
It does. I mean, I just think that it is appropriate to list the entities that we are in fact monitoring.
Which we do. Our current regulations.
I know. That's why I'm slightly confused on it. I mean, I think we're effectively doing this. That's where, when we do look at the net cost and and the level of purchasers, we have all that data. So I mean, I think
that's right.
We have all this and we're doing all this.
That's right. Then Dr. Levy, did you have questions?
It does seem like the issue here is that the cost review is more inclusive than what the UPL is, and perhaps that is what's leading to the confusion. Like, we do a cost review where we looked at the Medicare prices and things like that, but we don't actually regulate, or we don't have upper payment limit, rights within Medicare within the state.
That's the issue that I think is being flagged. Yeah. So our cost review is for the entire Maryland market. We look at Medicare, we look at Medicaid, we look at the commercial market. But one of the policy tools that you have is upper payment limits. And when you set upper payment limits, those are only for state and local government, our governmental entities. So I think
a subset of the commercial market, which
exactly
is confusing people here, I think.
Yeah, that's my understanding as well, that the only thing we're doing is things that the state government is paying for or is it involved in, but commercial and Medicare is not part of our charge.
That's correct. So the discussion, I think we had this when we were originally doing the cost review study process, but there can be a finding where you look across the entire state healthcare system and there's a population that has trouble affording their drugs. So you can deem a drug to have an affordability challenge. But then when we actually look at the drivers and the affected patients, you can say setting a UPL for state and local government doesn't address the affordability challenge that we identified through the cost review. Instead, we recommend these other policies, these non-UPL policies, right? So that's an outcome. And I think that's kind of where the confusion comes in. They basically want you to do your cost review studies only on state and local government, whereas the board has early on decided that you want to do your review across the entire state healthcare system. And we believe that the definition of state healthcare, the term state healthcare system reflects the entire state healthcare system, not just state and local government, because they're separately described in the statute very specifically. Okay. Any questions? I don't think there's anything we need to address on this.
No, I would agree. I think this is straightforward. So
okay, great. All right. Next comment. So concerns with the assumptions and economic impacts. So a number of commenters went through the economic impact and expressed specific concerns with the assumptions that we make. They expressed concerns that the economics impacts do not adequately consider the impacts on different members of the supply chain, such as impacts on pharmacies, providers, and patients. Staff has no recommendation on changing the economic impact. The board has discussed the implementation of UPLs for state and local government in a way that actually addresses a lot of the risks that the commenters address in the supply chain, right? So as we've discussed and kind of proposed as a methodology, the framework the board's discussed in open meetings does not change reimbursement throughout the supply chain. So that's why we were able to assume that the different entities throughout the supply chain would not necessarily be impacted. Any comments or questions on that?
They may be impacted, and we're taking that into account with our supply chain report, et cetera.
I think that's right. They're looking, so the regulations, the first section includes an impact analysis. And we basically, as part of that, describe the economic impacts of our regulation, which could include setting up payment limits. And we basically specified the entities that would be most impacted, which would primarily be between the manufacturers doing kind of rebates or chargebacks or something to the state governmental entities, which kind of leaves the rest of the supply chain untouched in our current framework for state and local government.
We also received some comments about, well, I think kind of outlining what I would consider to be unintended consequences of our actions. And so I think it is important in talking about the economic impact analysis that we are wanting to be aware of those. And that depends on people reporting up to us any impacts that they're experiencing that were not originally part of our kind of thought process. So I just wanted to say that we are open to continuing that feedback. But I did see that in the comments, outlining for private clinics and practices what they expected as impacts from actions with the UPL.
Yeah, that's a great comment. And we do get into that in some future comments below. So I do think it's an important exercise for the board to do, to anytime you're considering a policy, kind of go through the potential impacts. Right now, all of it is hypothetical, so it's difficult to react. I mean, you can kind of argue the opposite direction, where it could be positive impact, or as we intend for the policy to be implemented, it's a no impact. So that's kind of like if there was an impact, it means the policy is not being implemented as intended and planned as outlined in the economic impact analysis. So we do talk about that a little bit later in this presentation, but I think it's a good point. That is certainly one of the main jobs of the board, is as you consider policy, make sure that there's no unintended consequences, or minimize unintended consequences. All right. Any other comments on this? Okay, we want to go into the next section. So lack of specificity regarding comment opportunities. There was a series of comments. Actually, I'll just go through each of them. But one commenter commented on the comment opportunities in the UPL process. So the comment was that proposed regulations explicitly provide for comment opportunities at certain steps of the UPL process, but not for others. And they generally provide for public comment on any decision pending before the board, but fail to set forth any specific procedures or standards for such comment. We recommend no action. We just recommend seeing existing regulations setting the procedures for public comment. So we do have public comment procedures in 1401, 01, 05A and B. So these UPL procedures are layered over the existing board comment procedures, right? So all the things, like all the rules we've already set, still apply as part of this work. So there are comment procedures in place at this point. Any questions on that?
But are the UPL related, or I should say UPL specific procedures for comments in any way restricting what I would consider foundational as far as our public comment procedures?
No, I think the way, and I would invite council to weigh in, but basically we have baseline comment procedures that guide all public comments. And those are articulated in 140101, 05A and B. In some situations, if we want to go above and beyond what those baseline rules are, we do articulate opportunities for additional public comment that wouldn't otherwise be afforded. But in general, we have this baseline that I think this commenter did not appreciate that does basically set the rules for comments. And then we have additional rules for special circumstances that we create in UPLs basically. But whenever we don't have those special circumstances, it reverts basically to the standard commenting procedures that we have here.
This is council. The thing to note is that the public comment procedures track the board meetings, as there's specified procedures allowing for public comment at board meetings and public comment in relation to written public comment in relation to pending board decisions and agenda items. And so what the UPL regs do is all of those opportunities are available consistent with the board's work plan, but there are a few instances where something will be done in between those board meetings, and those are the instances where staff will post, for example, sets of recommendations, and then using another one of the public comment procedures, post the time period by which they'd like to receive comments back so that can be put together and then made available to the board at the next board meeting. So it's really when something is off cycle that it is specifically addressed in the regulations, or where there's, as Andy said, there's a specific need. But otherwise, the understanding is there's existing set of procedures that apply to all of the board's work, and these other procedures are layered over top of that.
Okay, but and thanks, Michelle, for that. So it's not as though they were based on Comar 140101, 05A and B, there were opportunities for public comment that are now restricted because of some of these off-cycle processes for the UPL. Any opportunities for public comment are still preserved as part of the UPL setting process.
That is correct.
Yes.
A and B refer to public comments at board meetings and written public comments in relation to agenda items for board meetings.
So all of the public comment opportunities that are addressed in these regulations are additive. Like it provides more opportunity for public comment than what as part of that process, if that makes sense. So it never restricts opportunities for public comment. It only provides more opportunity for public comment. So we have a series of comments on this space. So we can go to the next one. One commenter asserted that our regulations must provide a meaningful opportunity for public comment at every step. And staff recommends no actions. And you'll see here, we just referred to all the opportunities that there are opportunities for public comment. So we do, so we have the standard public comment procedures that we mentioned before. And then throughout this methodology, we talk about the different opportunities for us posting different methodologies and seeking public comment. So in 1401, 05, 06A, staff actually posts the methodology and seeks public comment. In 1401, 05, 06, staff posts the UPL values that were developed, staff recommendations for proposed UPL amounts with a description of the calculation analyses and relevant underlying assumptions, and then requests comment. So we do at key points ask for public comment here. So our response is that we don't see a need for additional opportunities for public comment, so that's our staff recommendation. Yeah, again, the underlying principle behind all of this is that all of the UPL procedures are layered over that initial baseline rules for public comment procedures. And I think that might be kind of what was missing as part of this comment letter. All right, next slide. Thank you, Christina. So one commenter or multiple commenters said that there's no minimum comment period or no standard comment period. So I think basically what they're asking for is every time there is an opportunity for public comment, having standardized timelines and dates in the regulations themselves. In 140105A and B, we have standard public commenting procedures. So again, we have that baseline and all these UPL regs are layered over that. And then other comment periods are being driven by when certain materials and analyses are posted and comments requested. And this is in conjunction with board meetings and meeting procedures. So just because each of these different processes and steps has kind of different needs and differentiation, we think that there's no reason to set a standard for each of these different items. Any questions or comment on that?
No, I appreciate all the comments that we are getting, and I think we're getting great comments.
Thank you. All right. So the next comment was that comment was mandating board disclose data where there's public comment opportunity. So multiple commenters assert that the board should revise its proposed regulations to make it clear that where opportunities for public comment are provided, the board will disclose the underlying data and information relied on to reach its preliminary conclusions, and to the extent that such data are not confidential. Staff recommends no action. And again, we have the proposed regulations that provide for staff posting methodologies and calculations and requesting public comment. So we see at all the key scenarios where folks will have meaningful public comment, we will be sharing enough analysis for the public to provide comment. So again, we have our process where we post the methodology recommendations and see comment, and then also the posting of the UPL values developed, staff recommendations for UPL amount with the description of the calculation analyses and relevant underlying assumptions. So we think that that addresses this comment, and we see no need for additional action. Any questions here? All right, next slide. Multiple commenters recommended providing specific opportunities for patient input, including through tools such as meetings and focus groups, and prioritizing patient input and experience as a key criteria. We have no recommendation at this time. We do have the standard process for public comments, and then also the 140101(6)(c)(1) provides opportunities to engage patients and the public through informational hearings. So the thing I wanted to start by saying is I think it's been communicated from the board in your open meetings that patient important is extremely important to the board. And staff was kind of looking for the opportunities to address this comment. And as we see it now, the board has many opportunities to receive patient input, including the public comment process. And then the hearing process that was established through these regulations, we saw as one of the best tools to gather patient input. So we had patient input in mind, specifically when we developed the informational hearings. So I think we don't recommend any changes at this time, but do acknowledge that we want to provide every opportunity for patient input, and do consider that one of the very important perspective in all this work. Any comments or questions on this?
One thing I would add here, yes, I agree with the comments and the underlying prioritization of the patient input, and also happy that we have this mechanism through the informational hearing. I'll admit that the process of how we do that is still unclear to me. It is still going to be something for us to work out, because it's one thing to provide an opportunity for comment, and it's another for that opportunity to be accessible to people, and so that they're aware of it. So it's not just this process of sort of passively making this opportunity available, but really being intentional in how we communicate that opportunity out into the community. That process is not yet clear to me, what we are able to do as a board, what the staff are able to do within our provisions. This informational hearing as well, I think more detail on that would need to be fleshed out to address even just our board needs, as well as what I think the commenter is looking for is more about the process.
Okay.
Yeah, I mean, I actually think this is a perfect venue for the stakeholder council, and I've always felt that since we first were formed. I think this is one of the great opportunities where patients can get in front of a larger group than the board, but yet they're all online. A lot of us sit in on those council meetings, those stakeholder council meetings as well, and we can watch them. But I personally think that would be a great venue and a great opportunity and a big help to us if the stakeholder councils could utilize some of their time for that. That's just my personal thought.
We
Yeah, I
certainly
like
think
that
yeah.
as well.
Yeah.
I think particularly because the stakeholder council does have multiple perspectives reflected therein, and getting their thought on how to, I don't want to say recruit, but how to solicit this input in a way that we think can be generalized in some way to understand the patient perspective, patient burden, and costs. The process is there, but where I'm really wanting to know kind of is what our latitude is within the regulations to publicize this, actively seek input from patients, and how that happens. So yeah, but I like the idea of using the stakeholder council as one avenue.
Yeah, and Dr. Nicklick, I just wanted to also kind of echo and reiterate what you said, where staff didn't see an opportunity to update the regulations that would address your concerns. It's almost like an implementation thing, but we agree that we need to work to identify and engage the patients that may have feedback for us. And we've tried in a few different forums. So we do have, you'll remember that we have kind of this like hotline and inbox where patients can come to us when they can't afford their drugs. We've actually, for the drugs in the cost review study process, reopened comment periods specifically seeking patient input. But it's very difficult. We reached out to clinicians that are treating these patients and still got very limited responses. So I think we are certainly open to continuing to think through the implementation. We just didn't see an opportunity to make the change in the regulations, but and do look forward to kind of working with patient advocacy groups as well to kind of find the best way to get engaged patients. So
I agree.
Great. All right, so we'll move on to the next session, the next section. So here's some technical comments on the UPL procedures and upper payment limit policy options. So one commenter recommended, actually there might be two kind of sets. Yeah, so there's almost two comments addressed in this. One commenter noted that the board does not have the authority to implement policies other than upper payment limits. And one commenter recommended that the board kind of table our upper payment limit work and actively seek the authority to implement other policies. And staff recommends no action on this. The proposed regulations are only for making recommendations regarding non-UPL policies. So we acknowledge that that's the role of the board in the non-UPL policy process, but don't see any changes necessary in our regulations. Does anyone have comments or questions on that? Ultimately, the non-UPL recommendations are going to be resolutions from the board, which are ultimately kind of recommendations, but I think is a useful tool that can be then turned into action through coordination with other entities. So.
Yes, I think as we move forward, we'll look for other opportunities, but I think we have one now, and sometimes it'll be appropriate, the UPL, and sometimes it will not be.
Okay, thanks. Next comment, one commenter recommended that we change the process to adopt a UPL policy option at the beginning of the process. The proposed regulation should be revised to require that the board formally adopt a recommendation of an upper payment limit as an appropriate policy option solution for a particular affordability challenge before selecting a methodology and developing a UPL amount for a particular medicine. So whether a UPL should be adopted is kind of tested throughout the process. I think the first indication for the board is we want to explore this as an option, but then there's the information gathering, and then throughout the process, we are kind of solidifying the appropriateness of a UPL. And kind of, I think one thing to note is at any point, the board does not need to finalize the regulation that implements the UPL, right? At any point, you can say, based on how this process is going and the information that the staff has given us, we've decided that we don't want to formalize it or propose a UPL. Staff may recommend a UPL, which would then allow us to continue to evaluate how a UPL would be set, but ultimately the board retains the ability throughout the process to determine whether or not a UPL should be adopted. So just as an example, if a UPL would address a market failure, but if the UPL number suggests that the magnitude of the market failure is not large enough, then it might not make sense to implement a UPL. So you're going to be gaining information throughout the process that you will want to take into account in your final approval of any regulation that sets a UPL. So we just, again, recommend no action because the process itself is important for your final determination of whether or not to implement the UPL. Any comments or questions on that? All right. Next comment. One commenter requested that regulations be revised so there's no combined decision making in a single meeting. The commenter stated the board must render decisions at each stage at a separate meeting with separate opportunities for public comment. And staff recommendation is no action, and we disagree with the commenter's interpretation. The proposed regulations provide for multiple opportunities for public comment on the preliminary determination of an affordability challenge, the draft and final report, information gathering, proposed policy options, and upper payment limit methodologies and calculations. If you follow all these procedures, the final actions and the way we've kind of presented it in our presentations throughout the process is that the final actions may be done in a single meeting, right? So you can do your adoption of the final cost review, adoption of the UPL policy recommendations, and the adoption of the regulations, setting the UPL amount in a single final meeting, right? Like we have kind of structured it so that is a thing that can happen. It doesn't necessarily need to happen that way. First, you need to finalize the report, and then you can do the resolutions and regulations around policies. But we do want to allow for that flexibility for that to happen in a single meeting. But that's going to be after, again, a very intensive and robust process with many opportunities for public comment. So we did just want to respond to that. Any comments or questions there? All right, hearing none, we will move to the next one. All right, factors of staff analysis of the UPL policy option. Multiple commenters propose that when staff recommends a UPL policy option, the factors that the staff may analyze be the same as the factors that may be analyzed when the staff recommends non-UPL policy options. Specifically things like strength and weakness of the UPL option, which is not currently in that list. So if you look at 14010505B2 and C2, some commenters recommend the same timelines for UPL, also recommend same timelines for the UPL policies and non-UPL policies. So our staff recommendation is that the supply chain already reflects the assessment of the UPL as the policy option. Also, a lot of the upper payment limit action plan kind of worked through a lot of that. But for the purposes of clarity, the staff recommends revising to include certain language around non-UPL policy actions in the section under proposed COMAR 140105C to include the strengths and weaknesses of the policy and potential impacts of the policy. So again, just trying to be responsive. We think it's a clarification more than anything else, but the staff is going to recommend amendments to the regulations to address this comment. Does anyone have questions on what this issue is or exactly what the commenter was, what their question or comment was? Or any comments or discussion on this issue? This is one of the more technical ones.
Yeah, no, I agree with the approach of clarifying just that this is a more inclusive set of considerations with what the staff has recommended.
Okay. Yeah. The gist is that they want the UPLs to kind of, the processes to be, more generally aligned. The other comment in terms of the same timelines on UPL policies and non-UPL policies, we see them as similar tracks and they may follow similar timelines, but we don't want to necessarily obligate them to remain on the similar timelines just because without knowing what the non-UPL policies that may be available, it's difficult to, there may be more or less robust need for more or less robust kind of processes to develop those recommendations. So we think it's important. They will kind of fall on parallel tracks, but like setting specific timelines for each of those parallel tracks, we find not appropriate this time. So
yeah, I mean,
Yeah,
I think,
agree.
I agree. I think if we go down the UPL route and decide that it's not necessarily viable, then we'll look at other options. So I think you don't always know when you begin the process exactly what are the options that you need to do. And I think we can, as we go through the process, we keep the public informed as to what are the decisions that are being made and the issues that are being discussed.
All right. So if we go to the next slide, thank you for that discussion. One comment recommends mandating that all factors be considered when evaluating policy options. They recommend that the board requires by express regulation to consider all relevant factors when evaluating policy options. Objects to the use of may. Staff recommends no action. The boards identify the factors that may be considered when recommending a policy option, and this approach ensures the necessary flexibility. So happy to discuss, but we recommend no action on this policy.
I'm unclear here, just because I don't see may in the quotes. Am I missing something?
They're objecting to our use of may in the regulations. So we say the board may consider these criteria. They want a shall, so you have to consider all relevant ones. And we think that that can be artificially restricting. Sometimes we may have, for certain elements, just different levels of access to data and things like that. So each factor may be more or less relevant in different circumstances.
Yeah, I do find this interesting because in my legislative past years, 99% of the people would want may versus shall.
All right, next slide. So this section is the UPL methodologies themselves. So I think there's some interesting discussion we can have here. I will try to go through these relatively quickly. We have about 14 slides left, so just noting time. At any point, the board can table any of these topics for a future meeting. So I did just want to flag that for everyone, but I'm just going to keep moving forward if that's okay with about 14 slides to go.
Yeah, Andy, I think you're absolutely fine. We've got plenty of time. We're going to stay here and finish this today. So
Okay,
just take your time. I want all the board members to feel comfortable, ask whatever, have any kind of dialogue, any discussion. I'm somewhat tired of hearing the negative that we don't give the time. So I absolutely want to make sure that everyone has their time to make sure that they get all their answers out there.
Thank you. All right, so if you go to the next slide, a commenter asked for the board to provide further details regarding each contemplated UPL methodology so that stakeholders can meaningfully comment. And we recommend no action. And again, the process is developed to kind of address this issue. So I guess at a high level, our methodologies, the way that we describe them, they're not recipes, but statements of frameworks to calculate the UPL. So it's basically again, the framework and type of analysis you would use. And then there's a subsequent step of the actual implementation of each of those methodologies or frameworks. So we post its methodology for recommendations on the board's website in advance of the board meeting and request public comment. And again, you can think of it again more of as like a framework. And then the public may also comment in the board meeting and has an opportunity to comment on the calculations. And I think this is the important part, the calculations and analyses performed by the staff under these methodologies, including any assumptions. So our short answer to this is folks will be able to actually comment on provide meaningful comment on the actual calculation itself and on the front end, the framework. It's like, is this the appropriate framework or methodology for calculating UPL? So we think the opportunities for public input are in there. So we recommend no action at this time. Any comments or questions on this?
No, I'd be very interested in their comments. So I'm looking forward to their comments on the methodology because it's not completely clear exactly for every drug, exactly how you should do it. So I think it's very important to get comments, but also recognize that each board member might take a different take on looking at exactly the same data. So, it's not like they're going to figure out exactly what the board is going to do based upon the staff recommendations.
Great. Okay, next slide. One commenter recommended that ask the board to ensure that its methodologies adequately account for relevant supply chain complexities that may impact both the implementation of the methodology and their suitability. And the staff recommendation is no action here. I think the board has spent the past few years just articulating how complex the supply chain is and demonstrating your awareness and understanding of how important some of these issues are. And the board's also cognizant of the scope of the UPL, which is just state and local government, which has a very specific mechanism of implementation. So we appreciate the comment, but recommend no action. Any comments or questions on that? All right, moving to the next one. A commenter urges the board to incorporate explicit guardrails against inconsistent application of analytical methods and considerations across different drugs. And we thought this was a good comment, and we appreciate the comment and would be interested in feedback, but we don't recommend revising the proposed regulation given the existing protections contained in them. So under our proposed regulations, the staff posts its recommendations for proposed methodology and contextual information in advance of the board meeting and seeks public comment on the proposals. Also in 0506A3, and then once staff completes the analytics of using the methodologies and information, the staff posts its recommendation for proposed UPL amounts within a description of the calculation and analysis and relevant underlying assumptions and seeks public input. And that's a kind of a long-winded way of saying that in principle, this is a good principle to have. You want similar situations to be applied similarly, but if folks think that that is not happening, they will have opportunities to provide comment throughout the process and point out any potential concerns that they have in this space. So we didn't see guardrails that could be put into regulations that would address this comment, but we think the process itself allows for it, basically through allowing specific commenters to kind of flag any inconsistencies or issues that they see.
So I guess my comment here would be, if we really want to respect the context and application of each drug, how do you guarantee that you're using analytic methods consistently? And should you even guarantee that you're using analytic methods consistently? I certainly would want us to guard against inappropriate application of any analytic methods that we selected. So that would be my point around the analytic methods, that I think it would be inappropriate that we guard against. And I don't know necessarily that I would look for similarity and consistency across methods, across different drugs. As far as the considerations there, I feel like we can think about some consistent or sort of an ethos or framework for examining the different drugs, because I think we're coming at each of these examinations from a single mindset, which is focused on affordability and trying to address sort of our main goals here as a board. So I would look for some consistency there as far as considerations, but I would definitely want to leave ours the flexibility to look at these methods and have some different approaches, but that are appropriate for the situation.
I totally agree with Barry on that. I'm thinking of things like therapeutic alternatives. There might be some drugs which have a generic that's a competitor, some that do not have a generic competitor, some that have 3 competitors, some that have no competitors. There's a whole series of things that make each drug unique, and trying to have one formula, one approach just does not allow us to do that. So I think we have to have the idea that we're going to use therapeutic alternatives as a consideration, but we can't be super specific on exactly how that would be implemented.
Yeah, and you can't be 100% consistent across, different drug chances or different drug types of drugs. Some for diabetes, or some are injectable, some are infusions, some are pills, some are different ways of doing things. It's different, so you can't do the same thing all the way across the board. We try.
Great. And again, just reiterate.
I echo the rest of the board members' concerns. And I did trying to take it seriously though, being consistent makes perfect sense to me, but I really struggle to think like, what would these guardrails actually be? Like, we have to do X and then we have to apply systematically. I think that would be quite challenging.
Yeah, we appreciate the comments. And ultimately, we think that the guardrails exist because we are showing the work, right? So this is a comment that they can provide, say, like, this is something that the public could comment on if they think that, that we're not following this principle. So
we also specify the factors that we are going to consider. So, I mean, I think that's very important to say the factors we're going to consider.
All right. Any other comments on this? We did think that this was, one of the, more comments that needed a response. So we appreciate everyone's discussion on that. Right. Any comments or questions? All right. Next up, commenters object to the proposed. Yeah, thanks, Christina. Commenters object to the proposed methodologies that use cost-effectiveness analyses and international prices from countries known to use quality-adjusted life years, QALYs. They contend that the board has failed to include safeguards in the proposed rulemaking that would protect people with disabilities and serious chronic conditions from decisions made in reliance on discriminatory value assessments. Staff recommends no action here. And I would just say that the board has heard and understands the concerns related to these specific standardized metrics, such as quality adjusted life years, and the potential unintended or discriminatory consequences of over-reliance or exclusive use and reliance on those metrics. However, to understand the affordability of a drug and be able to consider all the necessary information and literature, the board may consider all available relevant comparative and cost effectiveness research. So that's our general response, but would welcome any input or comments from the board.
Yeah, I don't think we should take data off the table. I think we should use as much data as we possibly can use. Some of us are good fans of QALY, some of us are not good fans of QALY. So I think having as much data as possible to make a decision is always a good thing.
Yeah, I think I'm just looking at this term UPL methodologies and wanting to just maybe clarify that we have certainly a framework that we've articulated for inputs in terms of sources of data and results and studies. Some will use CEA, some will use variants of CEA, like DCEA, the distributional cost effectiveness analysis, and other methodologies, trying to provide a more nuanced interpretation. And we're going to be open to all of that. I just wanted to highlight that CEA itself is one methodology that has itself spurned some additional variants designed to address some considerations that have arisen across subpopulations. All of that is, again, based on what's available in the literature and what the board can generate on the table. So definitely agree with Jerry.
Yeah, I think I would add the specific thing about this comment actually is it's saying we don't even want to look at international prices that may have considered, QALYs in setting their price. And I think I would sort of say, one, I don't think the board intends to have, a single definition of, oh, this international price came from here, so we're going to select it. And I would also kind of push back a little bit that, like, exactly what an international price is telling us is not completely derived from cost effectiveness analysis. There's many contextual factors there that go into prices well beyond, formal CEA. So I think by not allowing ourselves to even consider international prices that may have, incorporated these methods, I think would really hamstring us. And I think, I'd say, like, the point is we're not, there's not going to be one formula that reaches the price here. We're going to consider many contextual factors, of which international prices and, quite frankly, cost effectiveness based analysis potentially could be inputs to our eventual our eventual decision making framework. So I think hamstringing us by removing the ability to look at certain things is unnecessary at this stage.
And of course, we are considering, disabilities and serious chronic conditions. That's part of our job of trying to figure out what's affordable and what isn't. So, I think that we're doing that in part as part of our considerations.
One of the things I've seen with other geographies that have had more history with using some of the CEA and related methodologies in decision making is that they're also evolving their process, to Joe's point. And so it's not only looking at their single number and their output, for our purposes, but also looking at the process and how that has evolved. And it certainly has evolved over time. So just seconding points already made.
And the other thing to recognize is that we look at out-of-pocket expenditures, and we look at it not just at the average out-of-pocket expenditures, but at the 90th percentile of out-of-pocket expenditures. And those are most likely to be people with disabilities or serious chronic conditions. So we're looking at it from those people with a financial perspective as well.
Great, thank you. I think that's a great discussion, and we appreciate the feedback. I think it's an important comment, but I think the discussion kind of reflects the board's perspective. So thank you. So we may move on to the next one, and Dr. Levy's comments were a good transition into this one. One commenter suggested that it's inappropriate to consider international prices when setting UPLs because there's substantive difference in different international markets, right? So just different characteristics that may drive different international prices. I think the board kind of had this conversation when you were passing the regulation. So the staff recommends no action. It seemed like it was a proactive decision for this to be an input that you can consider. But defer to the board if you have any additional thoughts or feedback on this.
I mean, as I said before, I agree that pulling numbers off the shelf from another country's context does not make sense. I mean, there's variation in, market forces and willingness to pay in one place versus another that are quite significant and should be acknowledged. And I don't think, having a on the shelf, we move one price to here makes any sense. But I think it is a very helpful metric with which to help us in our decision making.
But again, it's a factor for us to consider. If something costs $10 in France and $1,000 here, there's a reason for that, and we need to take that into consideration when thinking of things that are affordable to the state and our patients.
Yeah, and just over the years, I mean, in drafting regulations, you wouldn't take anything off the table, so to speak. I mean, you'd want every tool in the toolbox that you could possibly have, or everything that you would not necessarily consider as gospel, but that you would have the ability to take a look at it. So this isn't, to me, something that would find its way through regulation.
You're muted, Andy.
Andy, you're on mute.
Thank you. So the next comment asserts that the board does not know how describe how comparative effectiveness research may be used in decisions related to therapeutic alternatives. And they note that treatments often impact patients very differently. There can be variation. Cost effectiveness research kind of looks at the average, but not every patient is the average, right? So they just wanted to flag that issue. And staff recommends no action on this. The board acknowledges that the impact of specific treatments may vary for each individual patient. And I think we want that input and perspective as part of this process. And we've gone over a few times the different opportunities for the public to provide comments on the methodologies. And this is a specific issue that they can kind of comment and make sure that we're considering throughout the process. Any comments or questions on this?
Yeah, I would say not all comparative effectiveness research, is of equal quality. And maybe that is what this comment is getting at a little bit is, there are sort of levels of evidence and quality of evidence that I think the board is perfectly capable of taking on, our assessment of these are good studies that show that this, in a real world population is going to, lead to one outcome compared to another. And I think there's real legitimate, scientific complexity to some of these questions when you're looking at comparative effectiveness research studies. But I think that is exactly what the board and the staff is going to be able to take on is the assessment of that.
think we can move on to the next section. So we have two kind of sections left. This one is additional considerations, so the impact on Medicaid best price, patient access, benefit design, and provider behavior and out-of-pocket costs. So if we move to the next slide, one comment or several commenters directed the board to explain in the regulation of how it would ensure that a UPL not impact statutory or regulatory amounts such as Medicaid best price. Staff recommends no action here. By the regulation, the board's articulated a statement of its policy that it shall not set an upper payment limit that impacts statutory or regulatory metrics such as best price. So we recommend no further action with respect to the statement. You know, this regulation is a statement of policy. We don't think there's any additional information needed in the regulation. Any comments or questions on that? All right, we can move to the next slide. Commenters urge the board to carefully and specifically consider if UPLs could adversely impact on access to the therapy, including pushing patients towards the therapeutic alternatives. One commenter suggested adopting an additional specific criterion that would consider the potential impact on patient access due to a UPL. And staff recommends no action here. The regulations include a number of protections to ensure access to drugs that can be subject to the upper payment limit. At the highest level, I would just start by saying that the purpose of upper payment limits is to increase access to more affordable medication. So that's, you know, the guiding principle that the board seems to be following. And then we also have the criteria for setting upper payment limits that the board shall, quote, set an upper payment limit in a way to minimize adverse outcomes and minimize the risk of unintended consequences. So this is specifically something that this board will need to consider in your development and implementation of an upper payment limit. Second, the board is required to establish a monitoring plan that's going to carefully monitor for impacts to access due to shortages. And then finally, you have a reconsideration process. So if you ever set a UPL and then want to reconsider it, during that specific process, the staff shall present to the board the estimated impact of the UPL to date, such as savings estimates, estimated impact on the access to the drug, estimated impact on access to the drug. So all to say, you're considering this on the front end, and then we also have protections on the back end where if this does happen, you have a way to kind of address that. So at this point, we think these issues are addressed in the regulations and recommend no action. Any comments or questions on that?
I think it'll be relatively easy to do this for state and for Medicaid. You know, we'll have to take another look at this if we ever decide to, and we're allowed to look at everyone in the state of Maryland. But right now, I think this is pretty straightforward.
Okay, great. Any other comments or questions? Okay, we are getting to the home stretch. Next, we have the UPL could impact benefit design and prescriber behavior. So one commenter alleges that the UPL could impact benefit design, which could prompt providers to adjust referrals, prescribing, and acquisition patterns for UPL selected drugs. And this could lead to provider pressure to choose specific low-cost medications, not necessarily the product deemed most clinically appropriate to the patient. So the staff recommends no action. I think, generally disagree with the commenter's interpretation. So to the extent that the comment speculates, so ultimately this is kind of speculation on what could happen here. So to the extent that the comment speculates the behavior of different entities, I think we recommend that we take no action at this point.
Many insurance companies commercially already do that.
I think that's a good point of how is this not the existing circumstance, but ultimately a lot of this is just kind of speculation, and staff had trouble kind of directly addressing anything. Anything the board wants to discuss on this, or move to the next slide?
I think again, we'll continue to monitor this and see if it happens, but I don't think it's likely to happen for Medicaid, and I don't think it's likely to happen for state employees. But again, we might have to take a look at this if we ever get the opportunity to look at it the issue more broadly.
One commenter, thank you, Christine. We can go to the next slide. All right. One commenter recommended that we consider out-of-pocket costs for patients. So commenters urged the board to consider direct patient costs as part of their analysis when determining a UPL. Additionally, one commenter recommended considering and weighting the costs relative to patients higher than other considerations. Staff recommends no action, and that's because we think that the regulations already account for this. So the board may consider out-of-pocket costs as part of the contextual information in 1401, 05, 06, C1 and 3. And then also the board may consider out-of-pocket costs when setting UPL in 1401, 05, 06, D3. So I think we would agree with the commenter that out-of-pocket costs is an important consideration, and just reiterate that the board is already considering that, or would already consider that. Any comments or questions there? All right, moving on to our final section. We are down to the last 3 slides. Monitoring UPLs. So UPL suspension, FDA shortage list, and patient feedback. If you go to the next slide, Christina, one commenter urges the board to establish standards and processes for determining the circumstances under which a UPL suspension could be appropriate and lifted, and the length of the suspension. And we would just say that a lot of the suspension scenarios can be very dynamic. So these regulations provide the necessary flexibility to account for different circumstances that may lead to the suspension of a drug. So again, probably no hard and fast rules that can be established, just because there are a number of different circumstances and situations that could create this scenario. So we recommend no action at this time. Any comments there?
We do have one, I think, in the provisions, which is if the drug goes into shortage.
Right, that's correct. Yep, that's correct. And that one is articulated. Yep, that's right. Thank you. All right, next slide. Next, there's a comment on the FDA shortage list. The commenter urges the board to revise the proposed regulations to require at least monthly checks of the FDA website. Concerning the FDA shortage list, staff recommends no action here, ultimately just because this level of detail is not usually necessary in regulations. This is kind of an implementation and operations issue. But yeah, I think we think no changes are necessary for the regulations here. Any comments or questions on this?
That presupposes that there will be a continuing FDA and FDA shortage list, but that's another story. That's another story.
All right, and then we'll move on to our final slide. Use an active monitoring plan to approach for patient feedback. The commenter urges us to use an active monitoring program for patient feedback throughout the working and through working with patient advocacy groups. Staff recommends no actions to the regulations. The regulations basically just establish that we will develop a monitoring plan to monitor the impact of the UPL. This is going to include passive monitoring, allowing patients and stakeholders to report adverse events. And we are looking at active monitoring tools. We were originally thinking primarily for wholesalers and pharmacies, because there's existing surveys that exist. But we can certainly consider trying to do something similar for patients rather than just relying on the passive monitoring there. So I think that's something that we would address through the monitoring plan. And we'll do that in accordance with the proposed regulations of 1401, 05, 08B. Any comments or questions there?
Yeah, I would definitely advocate for an active monitoring approach, because the passive one, there can be selection in terms of who reports up to us, which would not serve our purposes. So really kind of detailing that active monitoring, I think, would be important.
Great. And we'll take that into consideration as we pull the monitoring plan together. All right, so that concludes the presentation from the staff for this part of the working session. Again, this is not necessarily a comprehensive list of all the comments. These were the comments that we pulled together for our first working session. So all to say, there may be a similar presentation, though likely not nearly the volume of this to address any outstanding comments. So if board members saw comments that they wanted to specifically address, or even probably the public is welcome to flag things too. We will have kind of a similar presentation in the future, again, not nearly as long, to work through any outstanding issues. But thank you very much for the board's time, and I think that was a very helpful discussion. So thank you for the guidance.
Great, thank you, Andy and Michelle and Christina for putting everything together. Board members, thanks for the participation. I'm going to pass on the administrative update with Andy since we have a board meeting at the end of March. But Christina's got a legislative update that I'd like to give her a few minutes. Christina?
Thank you, Van. So the PDAB continues to track legislation. We've been answering questions for legislators, and we've been providing information as necessary regarding policy. We would like to provide a quick update on House Bill 424, which is the Prescription Drug Affordability Board Authority for Upper Payment Limits, Lowering Prescription Drug Costs for All Marylanders Now Act. House Bill 424 creates a process for the board to set upper payment limits for payers in Maryland after the board successfully implements upper payment limits for state and local government. This bill passed the third reading on the House floor last Friday, February 21st, and has crossed over to the Senate. So we're going to continue to track this bill and other relevant legislation.
Okay, is there anything else we need to know? How about the budget? Everything fine with that?
PDAB does have their budget hearings coming up this week and next week, but I can let Andy provide an update on that.
Yep, we look forward to the budget hearings and have no concerns.
Okay. Is there anything else, Andy, that you have?
Nope, just very much appreciate your time. Yep.
If not, thank you very much. Again, reminder to the board, our last virtual for the year will be March 24th at 2 p.m. Christina, there's no stakeholder council meeting in February, correct?
Correct. The next stakeholder council meeting will be in April.
Okay. Okay. I'll go around the table. Is there anything from any of the board members? Jerry?
So the only question I have is, are we going to have any interim meetings before March 24th? And if so, could we get them scheduled? Andy mentioned one about legal issues, etc.
I think the answer to that is no. That's why we tried to get whatever we could today, and then we turned this into a work session to hopefully get everything ready for March. I mean, our goal right now, we lost an employee, as many of you know, to CMS a couple weeks ago, and we lost the administrative staff person as well. So we're down again to 3 employees, and I think their focus and goal is to get everything ready for votes and to have a lengthy board meeting March 24th, unless you have something to add to that, Andy.
No, nothing to add here.
Can I chime in? You said the last virtual meeting for the year. Does that mean we're going to go back to in-person meetings? And do we have the schedule going forward?
Well, you have the schedule going forward for the rest of the year, unless there's special meetings, as we seem to always have. But we went virtual, as you recall, or should hopefully remember, because January and March, because of the legislative session and they're out in the middle of April. So I would think that we would go back, and May meeting would be in person in Annapolis.
Dr.
I
Lee,
found the calendar. I didn't see it in my calendar, and now I found it. We're good.
We'll resend all the dates too.
Okay, Joe, and anything else? You good?
No, nothing from me.
Stephen?
No, I'm just looking forward at the calendar. September 22nd is going to be a problem. It's the beginning of a Jewish holiday.
Okay. Well, we can deal with that. Barry?
Nothing for me. Thank you.
Okay, with that, I'll entertain a motion for adjournment.
So moved.
Second?
I second.
Thank you very much. We stand adjourned until March 24th. Thank you, everyone. Have a nice day.